Thromboangiitis obliterans or Berger's disease. This is a condition characterized by occlusive disease of the small and medium-sized arteries, thrombophlebitis of superficial or deep veins, and Raynaud's syndrome, occurring in male patients in a young age group. Usually one or two of these manifestations are present, and occasionally all three. This condition does not occur in women or non-smokers. The common arteries that are affected include the plantaris, tibialis, radials, etc. Histologically, localized inflammatory changes occur in the walls of the arteries and veins, leading to thrombosis. The usual symptoms and signs of arterial occlusive disease are present. Gangrene of the toes and fingers is common and progressive. The symptoms and signs of lower limb arterial occlusion. Intermittent claudication. This is a cramp-like pain felt in the muscles that is brought on by walking, not present on taking the first step, and is relieved by standing still. The distance walked is called the claudication distance. Things like walking uphill, against the wind, alter it. So do the speed of walking or changes in general health such as anemia or heart failure. The pain is most commonly felt in the calf but can affect the thigh or the buttock. Rest pain. This is a severe pain felt in the foot at rest, made worse by lying down or elevation of the foot. Characteristically, the pain is worse at night. It may be somewhat relieved by hanging the foot out of bed or by sleeping in a chair. Coldness, numbness and paresthesia. These are common in moderate to severe ischemia. Color changes. Initially the skin is blanched and later a purple discoloration may be noticed in light-skinned people. Ulceration and gangrene. These start as painful superficial erosions between the toes. Later, small, shallow, indolent, non-healing ulcers may occur on the dorsum of the feet, on the shins, and especially around the malleoli. The blackened, mummified skin and tissues of gangrene are unmistakable. Pre-gangrene. The combination of rest pain, color changes, edema, and hyperesthesia with or without ischemic ulceration is frequently referred to as pre-gangrene. Temperature. A severely ischemic foot is usually cold, but sometimes paradoxically may feel warmer than the non-involved foot because it tends to take the temperature of the surroundings, and staying inside warm wet clothes may make them feel warmer. Sensation and movement. Acutely ischemic limbs are frequently paralyzed and are without sensation. However, chronic ischemia could produce hyperesthesia. Arterial pulsations. Arterial pulsations below an occlusion in a main artery is usually absent or diminished in the presence of good collaterals. In patients with vascular symptoms, it is standard practice to feel the pulsations in the radial arteries, the carotid arteries, the popliteal arteries behind the knees, the posterior tibial arteries behind the medial malleoli, and the dorsalis pedis arteries on the dorsum of the foot. Diminution of pulse could be appreciated by comparing with the other side, provided the latter is normal. The disappearing pulse. When the peripheral pulses are apparently normal, exercising the patient to the point of claudication may unmask the effect of an arterial obstruction by causing the previously palpable pulse to disappear. Arterial bruit. A vascular examination should include auscultation of the subclavian arteries in the subclavicular fossa, the carotid arteries behind the angle of the mandible, the abdominal aorta, and the femoral arteries in the groins and over the adductor canals. Systolic bruits indicate stenosis. Venous refilling. The lower limb should be elevated for about 30 seconds and then laid flat. Normal refilling occurs within seconds. Impotence. This occurs with occlusion in the region of the bifurcation of the aorta and the internal iliac arteries. This is called Leriche syndrome. Investigation should include tests like ESA, autoantibodies, coagulation screening, and lipid profile. The treatment is total abstinence from smoking. While this will arrest the disease, it will not reverse the established arterial occlusions. Pentoxifylline or Trental could be used. Sympathectomy and amputations may be required. Chemical sympathectomy and radiographic guidance could be carried out using 5 ml of phenol in water with a 1:16 dilution. Laparoscopic left lumbar sympathectomy. The patient is positioned in the left renal position. The left side is almost vertically up and the kidney bridge is elevated. The balloon dissector is made as follows. A glove is tied to the 10 mm port and the finger portions are individually tied. A small incision is made midway between the costal margin and the iliac crest. The muscles are separated using blunt dissection with the finger, and the peritoneum is separated away from the psoas muscle. The balloon dissector is then placed inside the cavity that is created and inflated using the BP cuff. The telescope could be used to see how the dissection is proceeding. The balloon is removed and the trocar is placed in, and the gap is closed with a suture around the wound, which is packed with a gauze piece. This would prevent the air leak. 2 5 mm ports are placed under vision at a convenient place. First, the psoas muscle is identified, and it has a genitofemoral nerve emerging through the fibers. Blunt dissection exposes the aorta. The lower pole of the kidney is palpated through the peritoneum, and at this level, dissection between the psoas muscle and the aorta exposes the second sympathetic ganglia. This ganglia and part of the trunk are then divided and sent for biopsy. No drains are used and the incision is closed.